When?
So today we're going to be talking about toxic optic neuropathy, and we're only going to be talking about very common toxins, although there's a whole long list of toxins that can damage the optic nerve. The prototype for toxic optic neuropathy clinically is the development of a central scotoma or a secocentral scotoma, and that's because the papillomacular bundle is very highly metabolically active, and so when you're exposed to a toxin, the central fibers are the ones that go out first. So they usually have decreased visual acuity in addition to their central scotoma, and because it's a toxin, it's usually bilateral and symmetric. Initially, the disc looks normal, but over time, because it's papillomacular bundle, there'll be temporal pallor. So over time, we have a normal disc that becomes a pale disc, and that optic atrophy is normally papillomacular bundle, which means temporal pallor. And we can see that sometimes on OCT, where it will be normal initially, and over time, we'll see the nerve fiber layer drop out in the papillomacular bundle. The patient won't have an RAPD because it's bilateral and symmetric disease. The rest of the examination is typically normal. So the prototype for a chronic toxic optic neuropathy is ethambutol. So a patient who's 45 and has pulmonary tuberculosis and is on ethambutol presents with a bilateral, painless, and progressive central or secocentral scotoma. They have 2400 vision and they have a normal fundus. Ethambutol is the most likely cause for that type of toxic neuropathy. However, there are acute optic neuropathies that are toxic, and the prototype for that is methanol. So again, a 45-year-old white male presents with acute bilateral simultaneous loss of vision to count fingers, a central or secocentral scotoma, and the fundus could be normal or a swollen disc, and we should be worried about methanol. Usually that's because they've drank something like moonshine or some other product that contains homemade alcohol that hasn't been distilled properly, and sometimes the person is being poisoned. So it could be ethylene glycol or methanol if they're being poisoned by someone. And so we're going to be looking for the metabolic acidosis and the anion gap. Metabolic acidosis and methanol, we would be giving fomepizole if we have it and dialyzing the agent out. So in the acute setting, we want to be thinking about methanol, including suicide attempts. So we can have an inadvertent, accidental, or purposeful methanol exposure. So those are the two major categories, acute and chronic. Acute being methanol and chronic being ethambutol. You should know that there are other toxic optic neuropathies, including linezolid and other agents that cause optic neuropathies, but not in the pattern of toxic optic neuropathy. But if you just knew these two, the acute setting methanol and in the chronic setting ethambutol, you'd probably be good for the toxic optic neuropathies. For ethambutol, it's a dose-related phenomenon. The dose is normally 15 milligrams per kilogram. We're talking about a low risk, but once you start getting to 25, 30 milligrams per kilogram loading doses, there's a significant risk, somewhere between 6 and 10% risk of having a toxic optic neuropathy. The thing we want to know about in ethambutol is their renal function, and so if they have chronic kidney disease, they're on ethambutol, we need to follow that patient monthly to try and prevent the toxic optic neuropathy. Now, you don't have to do a full exam on the patient, but someone has to check their vision every month. And as opposed to something like hydroxychloroquine, where it's a dose-dependent phenomenon, it takes time to get the toxicity over 5 years, ethambutol can literally blind you in 3 months. So be very careful with ethambutol. And I hope that you'll be able to recognize your next patient with toxic optic neuropathy.